Everyone, welcome back to my channel. So this video is going to be a little bit different than my typical videos. Normally my channel is geared around like beauty and hair and lifestyle videos. I think a lot of you know that I am a nurse, and I've done like I think one video on like nursing and my experience in school and taking the NCLEX, and I get a lot of requests to do more nursing related videos. I really didn't think that many people would be interested in it, but apparently a lot of you are nurses in the medical field or thinking about going to nursing school, and you want to see more about my experience. I'm an ER nurse, and so I get a lot of questions about, can you do a video about life in the ER and what it's like a typical day? I plan to try to do a video like that. Obviously I can't film while I'm at work or really give like a whole lot of specifics about you know, patients and cases that I have or so. But one thing that kind of just really spoke to me, and I've been thinking about whether or not I want to do this video for a really long time, is a video on kind of like why the ER is so busy and why you wait so long, and kind of just like the way the ER is supposed to be ran, my experience, and just like tips and things to like let you know and kind of just like educate, because I want to use like my platform kind of just to like educate people on things that they may not have access to or they may not know, because a big portion of my job and the field that I'm in is to prevent you from ever even having to like step foot in the ER at all if possible, or even having to return if you are, you know, seen in one. So I made a list of different topics that I want to hit. It might be a little bit of a long video. It may be a little bit of like, you know, controversy or anything like that, but I'm just going to give you my experience on things. But before we get into that, please subscribe by hitting that button down below, and also the bell notification so you get notified whenever I upload. And yeah, this lets me know if you guys want me to continue doing nursing related videos. All right, so let's get started. Okay, so I've only been a nurse for 3 short years, like 3.5 years. And my entire experience has been in the emergency room. I'm now in my 3rd emergency room, just because I've moved. So I have a pretty like, you know, different, I've seen them ran different ways. I feel like I know the ins and outs, and so I can kind of give you like an experience about it. The first ER that I worked in was like very rural, like probably the only hospital within like a 30-mile radius for a lot of people. It was really in the middle of kind of a really small city, in the middle of nowhere. So it saw like a huge volume of people, really sick people. It was located right off of like a really popular interstate, so we got a lot of like, you know, car accidents, a lot of like people traveling from out of town. So I really loved that experience because I got to see like everything, because it was like the only hospital in that area, everything came to it. So I was there for probably like 8 or 9 months, and then I went to another hospital in a much bigger city that was a part of a larger hospital corporation, and the patients that we saw weren't as what's the word I'm looking for, like traumatic, because we had a level 1 trauma center like right down the street from us. It had a pediatric ED, so we wouldn't get any pediatric ambulances, we wouldn't get any trauma ambulances, no neuro ambulances, but we had the cancer center and like the sickle cell clinic at our hospital. So we got a lot of cancer patients, a lot of sickle cell, a lot of like geriatric patients that were really, really sick. It definitely was a hospital that had like a system that had more resources. So a different demographic of people. They were a little bit younger, a little bit teeny bit probably more educated, had, you know, a higher socioeconomic background. So that plays in part with things. And then the hospital I'm at now is a even bigger hospital corporation, probably like, I mean, it's huge, the amount of employees that there are, probably like 70,000 or so among all the campuses of hospitals. The ER that I'm at is the biggest one I've been at. There is a maternity hospital attached to the hospital that I'm at, so we definitely receive maternity patients. We also get pediatric ambulance, like EMSs or so. We have cath labs at this hospital, so we receive your STEMI patients or your heart attack patients. We accept them as well. We get, some CPRs in progress, some trauma, so that, it's definitely more. It kind of reminds me of like the hospital that I first was at right after school, but it's like more resources. So that plays a part in it also. So I just want to give you the rundown of how I feel like an average, not even an average, but the different types of ERs that there may be. So the ERs that I've worked at have typically had about 25 to like 30 beds. What that is, it means like these may be semi-private or private rooms, and it sees a large amount of people every day, up into like the 150s to like 200 people a day at a hospital, at an emergency room. So you can imagine if you come into the emergency room and we have 30 beds and there's a patient in every one of those beds, there's going to be a wait. Like when I tell people that I don't have a bed to put you in, I physically do not have an empty bed that a patient is not already occupying that needs that bed to put you in. And that's just the fact of the matter. The machines that we do for imaging, like your x-ray, your CAT scans, your MRI machines, are expensive. I mean, like tens of thousands of dollars, working up into like 6 figures for these really high imaging machines. And like your hospital may have one. You may work at a hospital that has, or go to a hospital that has one CAT scan. That CAT scan is running all day long, scanning your ER patients as well as your in-house patients. And so it's going to require maintenance. It may be down. It may take a while for you to get that scan done because they have 20 different CTs they have to do. And it's just going to take 15, 20, 30 minutes to do one of those. So it's just a matter of that. So I will let people know, in case you didn't know, Monday is the busiest day in the ER. If you are able to, like if you're fortunate enough to not have to be in the hospital for, an emergency, don't come on Monday. Everybody sits at home all weekend not wanting to come to the hospital because they don't want to be in the hospital on a weekend, and they come in Monday thinking that, Friday, Saturday is probably the craziest night ever, and that's not true. Weekend, any day of the week can be insane, but on average, Monday is the longest, busiest wait in the emergency room. Every one that I've worked in, it has been that way. Sunday probably following in next. How many doctors do you think are working in the emergency room? Probably not as many as you think there are. Currently, they do like 8 to 10 hour shifts, the doctors, and then we have mid-levels. Mid-level providers are your physician assistants and your nurse practitioners, your advanced nurse practitioners that are working under the guise of a medical doctor, but they're able to see patients and diagnose them and treat them as, also anything that they're concerned about, they run it right back to the doctor who's also in the ER. But everybody may not be seen by a doctor necessarily, but that doesn't mean that your care is any less. You're still being seen by an advanced provider. You're still getting the same care. They're, consulting with the doctor if they feel, they have any questions or if they need to or so. So budget-wise, hospitals cannot afford to staff an ER with 10 physicians. I don't know what people think, but max, the hospital that I work at, is going to have at peak hours, I think 4 physicians and 3 mid-levels, okay? That means that each physician probably has about 10 or 11 patients that they are seeing, okay? That's a lot of people. So unfortunately, I know they get a bad rep of being really short, seeming like they're not caring, they're in and out of the room, and that's just because of the patient load that they are taking care of. They can't spend 30 minutes in the room with you as much as they may want to, and some of them may. It can't happen. There's too much to be doing. They're getting constant phone calls. They're having to put in orders and read scans and look at lab work and discharge and admit people and doing procedures that may take extra time. They can't. And then for nurses, my patient load runs anywhere from 3 patients to 5 patients, which may not seem like a lot, like, oh, you only have 3 patients to take care of, but I'm in the emergency room and these patients aren't deemed necessarily stable at this point. I might have a stroke patient in one bed, I could have a cardiac arrest in another bed, and I could have a dislocated knee where we have to do moderate sedation in one bed, or a sepsis patient that is going to take up a lot of my time and my labor or so. Like those are really, really sick patients. So if I'm not in your room constantly, it doesn't mean I don't want to be. It's something that's keeping me from being in there. I had a sepsis patient. I have to start a couple of IVs. I have to draw several tubes of blood. I gotta get 2 sets of blood cultures. I gotta put you on the monitor, do an EKG, get a urine specimen. I have to make sure you're hooked up to oxygen or so. I have to get these antibiotics and these fluids going, and I have to do all of this within a certain amount of time, because research has shown that people have the best outcome when these things are done in this amount of time. And then my hospital is on top of that, watching me, saying, you have 30 minutes to get this done. You have an hour to get these antibiotics started. Just kind of understand that we are getting to you. When I say we are getting to you as soon as we can, we are getting to you as soon as we can. There is nothing I benefit from by letting you sit there and not drawing your labs or not medicating you and the doctor hasn't seen. There's nothing beneficial to that. I do not get paid by how long you are in the emergency room. The doctor doesn't get paid by how long you are in the emergency room. That's not how it works. My goal is to see you and get you out as quickly as possible, whether that is admitted or discharged. Our goal is to get you in and out as quickly as we can, because we have a lot of people to see. The way that the ER works is you come in and you are registered, you are triaged. Triaged means I get the nitty-gritty of what brought you to the hospital. I get your vital signs, blood pressure, your temperature, your heart rate, and your oxygen saturation. I need to get all of those things, and if anything is automatically critical out of that, if you come in and your oxygen sats are 70% on room air, boom, you're getting moved back quick. You're not deemed stable at that point, and therefore you're not safe enough to sit out in the waiting room to wait. You're gonna be seen, okay? So if we have that happen, sometimes we have to rearrange people that are already in beds. And what that means is I unfortunately may have to put you in a hall bed. And I hate hall beds. Trust me when I say the staff in an emergency room hates hall beds. We hate them. I do not want to sit you in the hall. It is embarrassing for you. It is embarrassing for me. It looks like we are not competent. But if I don't have a room and a CPR is coming in and you're stable at this point and just waiting for an ACE wrap or blood to come back or waiting for your ride, you're gonna have to go in the hall bed. You don't want to be the patient that's getting rushed back immediately. No one wants to. I'm supposed to triage you in 3 to 5 minutes. I get the nitty-gritty of what brought you to the emergency room, get those vital signs, and then I'll get any pertinent labs or scanning imaging that I need to do in triage. If you come in, you're like, hey, I fell and now my knee hurts really bad. We're gonna get an x-ray of your knee. If there's any appropriate medication I can give you, I'll go ahead and give it to you there while you wait for x-ray to come and get you, while you wait for a bed to open up. If you come in and you're like, chest pain, okay, EKG, chest x-ray, we're getting labs, checking those cardiac enzymes and the rest of your blood work, your electrolytes, your white red count, your kidney and liver function, all of that, we're getting that done fairly quickly. If I can medicate you with whatever's appropriate, I'll do it then. Don't think that you're just going to come in and say I have chest pain and automatically get a bed in the back. We're going to get the EKG. It tells me whether or not, hopefully, there's an abnormal heart rhythm right then. We're going to get your chest x-ray. We're going to get your blood drawn. If any of that stuff comes back and it's abnormal, we're pulling you out of the waiting room and you're getting a room. We're constantly checking these things. It's not that we're not doing anything. Unfortunately, if I don't have a bed and you come in and you're not emergent, you're going to have to wait in the waiting room until a bed is available, regardless of whether or not you come through the front door or you come ambulance. Some people seem to think if I call 911 and take an ambulance ride, I'm gonna be in a room immediately. That's not always how it works. If you call and EMS codes, in codes, and they say, oh, we got a lady who's complaining of abdominal pain for the last 4 years, probably gonna go to waiting room if you can sit there. if I have Meemaw coming from a skilled nursing facility and she's 97 and demented, she can't sit in the waiting room. She's gonna have to be in a hall bed or in a room where we can see her. And one great thing about where I'm working now is that we've rolled out this new plan where you're able to kind of like do a virtual chat with a provider that's actually in-house at another, well, they're located at another facility, but they sit there and they see patients in triage. So I triage you, they pop up on the screen, you give them your complaint, and they start saying, okay, we're gonna order this, we can order these meds, this, imaging, this blood work, and we can get all that going while you sit in the waiting room. I mean, I really feel like it helps things, getting done. And then we have a nurse that we can draw your blood up in triage, we can medicate you with whatever's appropriate in triage, we can get these things going so by the time you get back to a room, bam, your blood work's back, your scans are back. Hopefully, if we can medicate you, you're feeling a little bit better. It just moves things that much faster. So I feel like I've covered a lot of things. There's so much more that I could talk about, but I don't want this video to be like an hour long. But also another thing that I wanted to mention is kind of just like some tips on the emergency room and if you can avoid it. I feel that people know what the emergency room is for, but they abuse it. I think if you would poll America or people in general and ask them, what do you think the purpose of the emergency room is, they would give a completely different answer versus like why they are actually there. The purpose of the emergency room is to rule out that it is an emergent situation. So emergent pretty much means, do you need life-saving interventions, or are you at a very high risk of having some type of emergent event happen? People come in and you have chest pain and you've had several heart attacks and you've had stents placed and you're, diaphoretic, you're vomiting, this pain just won't go away. Seems emergent by all means. I have a toothache and it's been hurting me for 2 months, but all of a sudden, now I want to come to the emergency room. That's not emergent. And therefore your wait may be longer. So that's what I try to explain to people, or people that come in and are unhappy that they haven't gotten a specific reason as to why their stomach is hurting. So the role of the emergency room is to rule out life-saving intervention or high risk for emergent event. So we may not always be able to tell you what's causing your pain, but we want to do everything that we can to make sure that it's not going to kill you or you need to stay in the hospital for it, right? Because that's what an emergency is. So we may do, blood work and scans and medicate you, and if those scans and that blood work come back and the physician, the private provider doesn't feel that it's something that you need to remain in the hospital for, you are going to be discharged, and you are probably going to be discharged to follow up with a primary physician and or a specialist. And I think, the main reason why people come to the emergency room is because it's free up front. Like, we're not going to charge you, there's no copay to get into the emergency room, and so therefore people have just taken it upon themselves to use it as almost like a primary care office, and that's not what it's there for. Your primary doctor is there to monitor you all of the time, to kind of know more about your history. You come to the ER and we don't really know as much. We want to make sure, hey, is this patient so sick they need to stay in the hospital? And if not, go see your primary doctor. Go see this GI specialist, this cardiac, this cardiologist here, this orthopedist. Like, go see these people because they may require, more things that we don't do in the emergency room. Medicate yourself. Like, if you have a fever and you're able to take Tylenol or Motrin, take it if you can before you come to the hospital, because that's what we're gonna give you. I can't tell you how many times it's so frustrating to have a baby with like 102 temperature and the parents are like, oh, I didn't give him any Tylenol or Motrin, I just came to the hospital, or I didn't think you were supposed. I really had a grown man tell me, like, no, I didn't give any Tylenol or Motrin, didn't take any because I wanted you to see like how high my fever was, or And I told him, I said, that doesn't make any sense. I'm going to give you Tylenol and or Motrin, which you could have done yourself. So help me help you, because the Motrin I'm going to give you is a whole lot more expensive than the one that you're going to take at home. And also, a lot of emergency rooms, because people are now using the emergency room as like a primary care office, have started doing like a fast track, a minor care area, where they will take like a mid-level provider and they will see patients who are deemed like an acuity 4 or 5, which is pretty much like a non-urgent patient. If I come in for like a runny nose or like a cough for a couple of days or so, or something like that, probably going, or just like a little rash on my hand, you're probably going to be seen in like a minor care or fast track area. The goal of those patients is to get you in and out in 90 minutes if possible. So if you're in the waiting room and you start seeing all these people that go back before you and they got there after you did, there's just a bunch of things that go into consideration. It just maybe they're going back to get, an x-ray or CAT scan done. They're going back to get labs drawn. They're going back because they're going to the minor care unit, which is completely different than like the acute setting of the hospital, like the ER. It just may mean that that something came back in like their blood work or their scan, and it means they need to be seen sooner. So that's like one of the things. It just frustrates me when people get so upset because the wait time is like 6 or 7 hours, but there are 50 people. The other day we hit 40 people in the waiting room, and we had 37 people in the back using all of our, using all of our rooms and our hall bed. People are like, oh, I've been here 5 hours and you guys haven't done anything. It's like, I know exactly how long you've been here, and I am fully aware that the wait is long. But if you walked in the emergency room and there were 40 people in the lobby, you have to know that you might not be seen next, right? I don't know where I'm going with this video. It's really long. But anyway, I think my fellow nurses can feel me. So that's pretty much everything. This video is probably all over the place. It might have hit some, some hot spots for some people or so. Let me know if you want me to continue doing more nursing related videos. If so, what do you want me to talk about next? Yeah, thanks so much as always for watching. Don't forget to comment, rate, subscribe, and I will see you guys in the next video. Bye.